Dear colleagues, let me introduce my PhD title, The Use of Autogenous Tooth-Bone Graft in Overreach Preservation. My name is Eleonóra Sólyom, and my mission is to change the mindset of the tooth extraction. I think none of the extraction sockets should be left unpreserved. We will have 3 topics, 2 meta-analyses and 1 clinical trial. So every hour patient who comes to the dental office will lose 1 tooth during their lifetime. Without intervention, there's going to be a huge bone loss and also a huge soft tissue loss. In the first year, the width of the overreach can be reduced by 50%. And this deficiency of the facial bone anatomy is a critical causative factor for implant failures and also has a negative impact on aesthetic implant complications. But with an immediate surgical intervention, for example with overreach preservation, we can reduce negative horizontal bone changes by 16 to 40%. So we will have 3 topics. In the first meta-analysis, we are investigating novel graft material, and in the second, we are comparing the graft materials, and in the third one is a clinical trial about the novel techniques. So the first one is the safety and efficacy of autogenous tooth-bone graft for overreach preservation. Our aim is to investigate whether autogenous tooth-bone graft can be just as reliable for overreach preservation as the other bone graft materials. But what we know about the other ones? So they can be particulate bone graft materials, they can be xenografts, allografts, synthetic grafts. They are really easy to use, and they only have the osteoconductive effect. After 6 months, the newly formed bone proportion is really low. It can be from 30 to 45%. And what about this novel graft material? So the autogenous tooth-bone graft, of course it's autogenous, it has a really easy and rapid workflow. We just extract the tooth, as we would extract it anyway, we clean it, we won't throw it into the bin, we grind it as we could grind a coffee bean, we sterilize it, and after the sterilization process, we just fill it back to the extraction socket. We suture it, and after 6 months, we can see that the newly formed bone proportion can be up to 56% according to our preliminary data. It also has the osteoconductive and also the osteoinductive effect. And nevertheless, the price. So for example, the BIOS, which is a xenograft, costs 105 euros, this 1 box. And what about the ATB? It's only cost 41 euros. So the question is autogenous tooth-bone graft can be an effective way for overreach preservation? We would like to measure the changes in ridge width in millimeter. This is the primary outcome, and the secondary is the histological outcome. Our hypothesis that ATB can be as effective as other bone graft materials in preserving the width of the overreach, and it has a greater graft remodeling capacity compared to the other particulate graft materials. And why is it important? So ATB can be a reliable and a cheap alternative for ARP. And a greater graft turnover, that means that we have more bone, and if we have more bone, that can decrease the implant failure rate. So we did a systematic search in 4 databases, and after the selection process, we have 18 articles. And we also almost finished the data extraction process. The second one is the histomorphometric evaluation of overreach preservation techniques. So, just briefly about the graft materials, we have the particulate one and also the non-particulate one. The advantages of the particulate one, they are really easy to use, as we saw before. They have a space maintenance effect, but the residual graft particles can be up to 62%. And the non-particulated one, the advantage is that the residual graft proportion is from 0 to 20%. But what does it mean in the clinical field? So when we place an implant, I would like to see 100% bone-to-implant contact next to the implant. But if we use these particulated graft materials, we can see some encapsulated graft materials here, mostly in the coronal part of the extraction sockets. And this encapsulated residual graft can jeopardize the bone-implant contact. So what can I do? We open the flap, we can insert the implant here, but then we won't have this 100% or even less bone-implant contact, or we should remove these encapsulated parts. But if we remove these encapsulated parts, then I will lose the volume. So I would say it looks nice on the CBCT and on the volumetric analysis, but in real life, that's not the truth. So our aim is to investigate whether the same average width and the greater graft turnover can be achieved with non-particulated graft materials. So the question, can average preservation with non-particulate graft material be as effective as with the particulated graft materials? So the outcome is the percentage of newly formatted bone. Our hypothesis that with the use of non-particulate grafts, a larger amount of newly formed bone can detect. And the more bone, then that can decrease the implant failure rate. So we did the preliminary search according to 4 databases, and we also started the selection process. And the third one, the clinical, the radiographical, histological evaluation and blood flow analysis of hard and soft tissue changes following average preservation. So we will have 3 groups. The first one is the socket seal group. We just get some soft tissue punch from the palate and we suture it above the extraction socket. The second one is the extraction site development. It's a novel technique invented by Bálint Molnár and Windisch Péter. So we extract the tooth and then we would like to reconstruct this buccal bony wall. So we get a xenograft membrane, we fix it with titanium pins to the buccal bony wall just to reconstruct it. And after it, we grab some soft tissue from the palate and we suture it above the extraction socket. And the third group is a mixture. So we would use the ATB and also we reconstruct the buccal bony wall with the xenograft membrane. And we grab some soft tissue from the palate and we suture it back above the extraction socket. So the question is, are these novel techniques can be a predictable way for average preservation? And the outcome is the changes in range width after 6 months, and we would like to measure it intraoperatively. Our hypothesis that the XSD and XSD plus ATB groups are expected to have less pronounced horizontal width losses, and the XSD group is expected to produce the highest graft turnover. And why is it important? So in the clinical field, we are always investigating for novel and new techniques. We have the inclusion and also the exclusion criteria, and we have the main primary outcome, as I mentioned before, and also several secondary outcomes. So we will have these 3 topics, 2 meta-analysis and 1 protocol of randomized clinical trial. We are in the search for the best graft material and for the best techniques for average preservation, if I can say so. And I would like to close my presentation with this quote. This is from Professor Lars Hammarström. He is a biologist. He invented in 1996 a novel graft material, amdogain, and we are using it since that every day, really. So it's a really great graft material. And in 2016, they made an interview with him and asked how does he feel about this invention. And he only said that I have built many materials in life. I am happy that this one worked. Thank you for your attention.
Just a challenging question, I think, about your third project. So you already did you are doing the meta-analysis regarding the same topic. So you should have learned a lot of stuff, errors or mistakes that have been done by those researchers. Did you look into this, so the methodologies of these RCTs, or not only RCTs, and will you implement this knowledge in your trial? What is the knowledge that you gathered from those studies and you can implement in your study? Like, for example, sample size calculation, will you do some stuff like this?
Yes, thank you for your question. There's a huge heterogeneity in the articles, so of course we can learn something about these, but I think with the translational medicine we have a great support, so yeah, I think we can bear with it.
How many patients you need in one group, and what was the basis for that?
Okay, the sample size calculation generated 19 patients in every group, but we are decided to make an interim sample size calculation after 10 patients. So after 10 patients in every group, so after 30 patients, we make again a new calculation according to the preliminary results.
Yeah, I mean, this is just to teach all the others, you see, because this is not an easy stuff, as you know actually very well. I mean, just to have a good design, and even during the study that you may have to make changes if the kind of standard deviation of the variability is actually high. Thank you.
Question is the last one, the RCT. Why do you need measure the ridge intraoperatively and not with, for example, CBCT or something like that?
Yeah, it's a really good question. We could do on CBCTs as well, but sometimes this buccal bony walls is missing, so then we couldn't find a point to measure to. So that's why we are using an intraoperative measurement, and also it's easier to measure. But we will have a secondary outcomes, and in the secondary outcomes we will have the evaluation of a change of alveolar height and also the alveolar volume on CBCTs. So this is only our primary one.